And we are very lucky to have a Professor Yartsev today for today's webinar. He is a retired medical physicist from London Regional Cancer Center, Cancer Program. And he is currently he holds the position of Professor Emeritus, Western University, London. He is one of the eminent experts, and he has massive exposure in the field of medical physics and radiation oncology. He has completed his education in physics in 1971. Professor Slav secured his PhD in 1974. And he completed his postdoctoral degree, Doctor of Science, in 1974 from Lomonosov Moscow State University. He has been continuing education through various programs such as research projects, scientific conferences, academic and clinical activities, supervision and mentoring in medical physics and radiation oncology areas. To be very honest, it takes too time for me to introduce all his profile here. I would like to mention a few points. Among those, he has been actively involved in different conferences and different programs in the area of medical physics and radiation oncology, like Canadian Cancer Research Conference in 2017, Workshop on Integrating Biology, Physics and Radiation Oncology 2017, 15th Imaging Network Ontario Symposium 2017, Innovation in Cancer Therapy and Response Monitoring 2016, 42nd Congress of the International Society of Oncology and Biomarkers 2015, World Congress on Medical Physics and Biomedical Engineering 2015, the SRS and SBRT Scientific Meeting, 12th Imaging Network Ontario Symposium 2014, and for the 14th Workshop on Nuclear Physics and 8th International Symposium on Nuclear and Related Techniques. So he is a certified member of Canadian College of Physicists in Medicine. He has been leading a lot of research activities, and he is a research supervisor for PhD and MS students. Coming to his publication, he has a massive collection of research articles which is published in various reputed journals, international and national journals. So he has around more than 180 plus publications so far, and book chapters and published abstracts are there. Professor presented scientific conferences around more than 30 international and national conferences in the recent years, within 2-3 years. So with this, I would like to call up Professor for his lecture. We are very eager to have his session today. And also I would like to invite all the delegates for today's program. And I have one request to the delegates. Please be muted during these next 45 minutes. We want to listen from Professor, his ideas, his experience and exposure in the field. Definitely, we will have some interactive section in the end of today's lecture. Probably we will have 15 to 20 minutes of interactive session. And during the lectures, if you have any queries, doubts, please let me know through the chat box. Definitely, we'll have the discussion in the final part. So I would like to invite Professor Yartsev for his lecture. Please, sir. Thank you so much.
Thank you very much for this kind introduction. I'm sorry for technical problems. That usually happens in radiation therapy, as we all know, because we are all medical physicists and we know that problems occur where we don't expect them. So my talk is called New Ideas in Radiation Therapy because I thought that in these challenging times with COVID, it would be nice for physicists just to use their imagination and to go a little bit out of standard procedures and see what is can be new or not so new, as you will see in my lecture. Next one, please. So I will start with upright radiation therapy. Next one. So, as we know, now the tendency is to go to rotational delivery. And that means that there are more and more devices going to the gantry. So here you see a couple of examples of the machines. So I was working with tomotherapy for 13 years. And I know that, rotation, that they are adding more and more devices on this gantry. And because it rotates, so then there are mechanical problems all the time. So the cables are moving and there is leakage of water or anything like this. So, I think that Rock Maki, who is a professor in Wisconsin medicine, he wanted to have a proton source to go around the patient, so in rotation, but he understood that it's too heavy, so no gantry can hold it. Next one. So what is the possible solution? The possible solution is obvious, because even in the 1957, they had this patient position in a sitting position, in the upright position. But then this idea was forgotten. So when I'm saying it's new idea, so it's not really new. It was used long ago, but it was forgotten because we started with possibility of rotate the devices around the patient, and it was considered convenient. Next one. So here is the two chairs which are recent. So one was developed in MD Anderson, and its publication you should see here in 2017. And the other one, you see here the references for their sites is called Leo Cancer Care. And that is the center where they are developing a new kind of chair. So this chair is rotating around, it moves in all directions, so it's degrees of freedom. And they are working on the machine which has the imaging system at the same time and delivery system. So the main benefit of this is that we separate the problem of delivery system from the problem of rotation. So before, with all our machines which I have shown, delivery and rotation was on the same gantry. So now we can put for delivery in a static way. And that's why in this Leo Cancer Care, they now concentrate on using a proton source for this. So the protons, you can have it as heavy as you want, as long as it's static. But here the problem would be to have a very good chairs that we can control rotations and movements. So I recommend this to look at the Leo Cancer Care site. And also in China, I recently was connecting with those people in Shanghai. So they have developed a chair also for protons, which is only for head and neck cancers. So this chair has a possibility to incline for 20 degrees. So then they could have a non-coplanar system. Next, please. So what are the advantages of having patients in an upright position? So here on the left, you see an example when a lady is lying on the couch as in the position that we usually use for treatment. And we all know that when treating breast or even much more difficult double breast, you have this problem of beams going through lungs, and it's very difficult. While in upright position, which is shown on the right, the is by nature moved out of the lung. You can spare it much better. Next slide. So here two images which show lungs in upright position on the left and in supine position on the right. You see that the volume of the upright position is much larger, and that means that it will be easier to meet the constraints that we require for the quantity for the lungs. Next one. So the same for the prostate. If the patient is lying, so then the full bladder will change the position of the prostate depending on how much urine you have in the bladder. While if it is in an upright position, the prostate will remain at the same place. So those people, they have made investigation of the motion, and they said that it's much more stable to treat the patients in an upright position to the prostate. Next one. So here is the possibility how the prostate position is less dependent on the bladder filling. So you see here in the line bladder full, and in the dashed line bladder empty, and the prostate is almost the same, which will not be in a supine position. Next one. Second new idea, flash radiation therapy. Next one. So actually, it's again not a new idea. Even in 1959, Dew and Borg proposed that the dose rate and the oxygen consumption are related. And bacteria which were irradiated at ultra high dose rates had a greater survival. This was published, and even gave this idea of the hypoxic environments. Just look at this. That is the phrase from their paper. The time for which the bacteria were irradiated was shorter than the time required for oxygen to diffuse and restore the oxygen that has been depleted. But no one has paid attention to this, because at this time, technology was not good enough to have this ultra high dose rate for patients. Next one. So here you see how it was in the time. So there's a couple of publications and the years, and it was always for mice, and the people were just doing this evaluation, and it was outside the area of real interest for medical physicists, right? Because it was a pure research. and only this French and group from Switzerland, in good collaboration, managed to move it forward. Next one. Next. So, oh, one above you, you have missed one slide. Up. So here are the some publications, recent ones, which I recommend to look when you will have more time to see how this flash radiotherapy is working. Next one. So, and that is the survival of mice. There was their lung study, and depending on what kind of irradiation you are giving. So if it is mice which were non-irradiated but just got some cancer, they died before the 12 days. But if they are not grafted, they have no cancer, they live forever, right? That is blue line. And now, according to the dose, and it is conventional, so with the normal dose rate, or in flesh with a very high dose rate and different doses. And you see that in this case, survival is much, much better for flesh things, so that is this, and this, than for the conventional. And also the pulmonary fibrosis for the high dose rate is less than for 1.8 gray per minute. Next one. So then they had interesting results for healthy mice, and doing whole brain irradiation with small dose of 10 gray and with different dose rate. So control, they were not irradiated, their memory was good. So then on the right here, if the dose rate was low, the memory was not good. But if the rate was high, so that was the same dose what was given very fast. So then the memory remained in a good state. So that means that high dose rate spare the normal tissues. Next one. So here is the results for the skin, which were irradiated with conventional radiotherapy and at the bottom, and with flesh at the right, and how the skin was going. So you see, after 32 weeks, the skin is almost normal. So that has been well treated. So toxicity for the skin was not visible. Next one. So that is the results for the cat, which had a single dose of, they had this study on 25 to 41 gray, and they had mild skin reactions, no late effect, and there was 84 tumor control at 1 year. So, and those are the images of wonderful cat, which is cured after some time. So that is squamous cell cancer. Next one. And that was the more convincing results for a patient. And this patient is, in a way, completely unique. It's 75 years old male with disseminated cutaneous T-cell lymphoma. So he had progression with multiple systemic regimens over the first 10 years. Then he was treated with 110 courses of localized radiation therapy over the last 10 years. So he was given this kind of dose, and then there was always some severe acute toxicity, which were taken 3-4 months to heal. So here is this patient. So it's all over, everywhere. Next one. So now they have decided to treat this patient with 15 gray in 10 pulses for the whole time of 90 milliseconds. So that means that the rate was 167 gray per second, and that is electrons. So that is the day before irradiation. That is what this patient had. After 3 weeks, and after 5 months, it's completely cured. So I understand that this was new technology, so the patient has agreed for this completely revolutionary thing, but the results are amazing. Next one. So this is the idea of how it works. It's that reactive oxygen species are not enough in the tumor, so that the tumor is going to get this high dose and be cured, but for the good healthy tissues, there is no damaging effect. Next one. Next slide. So for the normal tissue, which is well oxygenated, the radiation resistance increases when we have a rapid change in oxygen. But for tumor, which is already hypoxic, we have only very small change in oxygen, and radiation resistance is unchanged. So the tumor is killed in the same way as before, but normal tissue is protected because it has this momentary hypoxia. Next one. So here is the plot from Wilson about the ideal pulsed flash radiotherapy. So what should be the dose, total dose? It should be more than 10 gray, but the mean dose rate should be more than 100 gray per second. And here on the right, I have, I think that it is, we know in physics that time and space are sort of related, right? Einstein told about this. So here I show one case when the lesion is one, but it is large in area. And if you have the same surface, but it is small scratches, they heal much faster. So the damage is less for the skin if you have very small areas of space. And that is the same for flash radiotherapy. You have a very small areas of time when you irradiate, and your healthy tissue remains in good shape. Next one. And the third idea is the big data radiation therapy. So myself with Professor Maki, we have published a paper in Medical Physics in 2013. And this idea is very dear to me personally. So we want to combine previous data with the patient particularity. Because right now, technology progress offers various treatment options. We have sophisticated delivery platforms, but with these sophistications comes a need for more and more labor. Image guidance improves accuracy and precision, but again, it increases treatment time and it's getting more and more costly, and we cannot treat as many patients as we want. So we would like to have a tool for selection of radiation therapy modality and protocols of image guidance customized for a particular patient without comparison of multiple plans. Because one option is you have a patient and you have several plans. What can we do? Next one. So we propose to create a database. So first in this red is the initial data. So we collect all pre-treatment information about age, tumor volume, all data from genetics, anatomy, as much as you can. So then you will have a pre-fraction information for the patients, how the patient was treated, what kind of shifts were used for setup of the patient. Then as the treatment goes on, we have information after each fraction, how the gross tumor volume changes, have we adapted plan or not? And finally, to collect in the same database, outcome data, overall survival, toxicity, and so on. So on the base of all these data, we'll create a model. So the model, which it's like artificial intelligence, right? So we have all this, and the more institutions, the more countries participate in this, it doesn't involve any new machineries. It's just computers. So you put this data, and then you have this model. So when the new patient comes, we have a pre-treatment information for this patient. We put it in consideration. Then when we go to using the model and this pre-treatment information, choose the optimal choice for this particular patient. Then the patient is treated. We have pre-fraction information, post-fraction information, and outcome for this patient. And you know, this outcome should be included also in radiotherapy, in radiation therapy option choice, because different patients, they want different outcomes. I talked with one lady, she said, you know, I only want to live enough to see my granddaughter wedding in November, so I don't care about anything else. So please, less toxicity, but I will live until that date. You know, it's personal choice. So, and this information is added to the model, and model is adapted all the time. So this evolving model. So, and we have started to do this for some cases, and next one. And I will give you one of these examples. Next slide. So that's the paper we have published in Future Oncology to understand the results of our study of liver cancer patients treated with different delivery techniques. What I mean by different delivery techniques, they were treated or by fixed gantry positions, so it was several fixed beams, 4, 3, or 5, but fixed. And the other techniques were rotational delivery, or tomotherapy, or VMAT. Next one. And in this direction, we have 195 liver cancer patients treated at our place. We looked at the outcome information. We collected all the initial information, and you see that everything is very similar for the kind of delivery which was used for the radiation, except only gross tumor volume. So gross tumor volume for radiation delivery, and that is fixed beam, were larger, because for larger patients, there were more problems with toxicity. So the doctors were biased. They wanted to treat more difficult patients with more sophisticated machines. So that was the doctor's choice. So now we looked at those two groups for rotational delivery and fixed beam delivery. And next slide. We have this found that for rotational delivery, we had this very interesting survival curve. That's Kaplan-Meier curve, right? So that patients which had area of liver receiving 24 gray, so volume of liver receiving 24 gray more than 18%, live better than the patients for this parameter were less. That was surprising for us. So how come that the patients with more area irradiated with this 24 gray, and why 24 gray? Because we looked at different isodoses, and for 24 gray, this separation between these two curves was the most visible. And this effect was absent for fixed beam delivery. So for fixed beam, we were not able to see it. So the question to you, so why we need, I will put it in other words, while we need to irradiate area for 24 gray in this patient. Next slide. Here is possible explanation. You have GTV, you have CTV dashed line, and you have PTV, yellow dashed line, for rotational delivery and for static force field. These red stars are cancerous cells. That's what is called microscopic spread. Because microscopic spread, that's something that we cannot see. We don't know where are these cancer cells. And in this cartoon, you see that these microscopic cells are all covered by 24 gray, because in rotational delivery, the radiation is spread equally in different directions. While in static force field, you will have irradiation coming from this area. So they will kill these cells, but those cells will not be killed because they need to be given 24 gray for being killed. And then you will have regression and you will have cancer. How do you like this idea? So it was without any additional experiment, without any mice, nothing, just looking at the collected data for 195 patients. Next slide. So what I think is happening, if we have this relative cancer cell density, so for the inside the tumor, gross tumor volume, there it's all cancer, right? Because it's relative to tumor, so 100%. Then the density of cancer cell is decreasing. And our wonderful radiation oncologists, they say, we need to have this margin between GTV and CTV to kill this microscopic spread. And they will put this arrow somewhere, right? Then we add another margin, physicists, to account for arrows in positioning and other arrows, and we have a planning target for them, PTV. So in this case, we cover by prescription dose this area, okay? So all those cells are getting prescription dose, if we assume that everything is right. Now, but there is diffusion, right? We in physics know that the cells are diffusing in different directions. Of course, further away from the gross tumor volume, there is less microscopic spread cells, but they still are. If the density is very small, then immune system, IS, is taking care of them. So they are killing them. But this area remains untreated. So if we don't have PTV high enough, then we are prone for recurrence of the tumor around the gross tumor volume which we are treating. And this problem is even more acute for proton therapy, because over there with this Bragg peak, there is no dose behind. So we don't have this flash of dose around. And we have noticed some cases when the recurrence of cancer was right behind this area of Bragg peak in proton-treated patients. So our goal is to kill all these cancer cells, how microscopic they are. How to do it? Next one. So in these conclusions, in order to prevent disease recurrence, some You see here in parentheses, optimum to be determined radiation dose is needed to kill the spread of cancer cells outside the PTV. So that is the work again. So you can either have experiments for this, so using petri dishes or mice or whatever phantoms, but also you can analyze the data for your previous treatments. So to understand what dose is needed for the specific microscopic cells density. So the second conclusion is that rotational delivery, making dose splash in all directions, does it better than fixed beams. Next slide. So that's the to-do list for this third idea. So first, we need to determine density of cancer cell versus distance from the GTV. So some kind of macroscopic spread map. There are some works now which are moving in this direction, how to see the single cells, but that's something which should be done. Then find minimal necessary dose to kill cancer cells with particular density, oxygenation, etc. So why this microscopic spread need less dose than the cancer in GTV? Because it is well oxygenated. So it doesn't need this high dose which we prescribe. So, and we don't want to enlarge the PTV. We need smaller dose, but we want to know what kind of dose it is. Number three, we need to have some measure of patient particular immune system, because that is necessary to eliminate isolated cancer cells with small density. And finally, to optimize the dose fall off for our plants, because you know, if there is bone and we know that the microscopic cells cannot go there, we don't need to put the dose there. Next one. So that's some information about our center, just for your information. So here is the stamp devoted to first ever patient with cobalt unit, and this has been done in London, Ontario in October 1951. And that's our center. So we have 2 Philips CTs, 8 variant accelerators, 4 of them true beam, 1 tomotherapy, HDR, LDR, photodynamic therapy, and that's our stuff. And I thank you for your attention. Hello.
Yes.
Thank you. Thank you, Professor Yartsev, for your wonderful presentation. You have gone through different areas, starting from the beginning of the upright radiotherapy to the positive impacts of this prostate treatment for the positive impacts on prostate treatment on the upright position. And you are very clear to go the importance of splash therapy. And of course, we came up with your work of doing excellent work of finding the the quality of rotational treatment in terms of the macroscopic spread map, finding the macroscopic spread map, and other criteria for the evaluation. So that was excellent talk, and I would like to invite the audience for their questions. Let's have 10 to 15 minutes of time for question.
So I see here several questions already. So let me see. So that is what is the rationale behind producing different response between tumor and normal tissue with flash RT? As you had mentioned, no time for oxygen diffusion, or there are other reasons. Right now, people are looking for possible reasons. So the fact that what has been determined now, that if we have a very high dose rate, the normal tissue is damaged less than tumor. And I think 2 months ago, and Physical of Medicine and Biology, there was a very interesting paper. I haven't included it in the presentation because of the time. You know what they have proposed? They proposed to use protons with very high energy, so high that the Bragg peak is outside the patient. So the protons are just going through patient. And they say that if we have these protons going through, the norm and the rate is very high, so that is flash proton beam, the normal tissue won't be damaged much, but the tumors will be damaged, just playing on this difference between tumor and normal tissue reaction to
Yeah.
Are you there, Yaslav? I think he's cut off, like there's no voice or movement. His video is frozen.
Yeah. Professor Slav, could you please connect? We are sorry, we are not hearing you.
I think it's something related to internet. We missed him.
Yeah.
Okay, let's wait for 1 or 2 minutes. Maybe he will reconnect it.
I think he is muted. Actually.
Yeah. Can you unmute yourself, sir?
Sorry to interrupt, sir. Could you please unmute?
You call him by name.
okay. Okay,
Sorry.
any more questions?
Yeah, sorry, we could not hear you for it. Please carry on.
So from which moment you stopped hearing me? Have you heard about protons going through the human body with Bragg peak outside the body?
We heard that, yeah. You
We
said
heard
that. Then
Okay, and also about the grid therapy with flash radiotherapy, when they had mice,
no.
and they put it in stripes. So the stripes, when there was high dose in areas of microns, and those areas were separated, and the sparing for the healthy tissue was much better. So you can combine, if you remember my scratches in presentations, so space and time together. So making it scratches in time and scratches in space, you will have even better sparing. And at the same time, there are some publications which show that flash radiotherapy is not such a silver bullet. So I think we are still in this area when we need more and more investigation. More questions?
Yes, we have another question in chat box. What about the limitations or restrictions on certain gantry angles in upright artery? Is it well efficient to treat tumors of all sides?
Well, it depends. As I told you, in Shanghai, their system is limited to head and neck cancers. But in addition, that they can be at an angle so that they have non-complanar fields. In Leo cancer care, this chair is designed in such a way that it can treat all kinds of patients. So there is prostate, head, and everything. So I strong because now they have published a white paper about their system, and they promise to have a clinical machine somewhere either in Singapore or in Japan or in Korea, because with FDA is difficult for them to have the approval, because now FDA is so overwhelmed with COVID problems. So, but in Asia, probably they will go clinical very soon. Leo cancer care. Okay.
Yes, that's fine. And we have another question. Can you suggest any literature for understanding the theory of superiority of rotational therapy in controlling microscopic disease outside target volume? We have observed recurrence outside the low dose regions in patients treated for liver SBRT. Hearing your lecture, we would like to evaluate these plans and to find any corrections.
Well, I can only give this paper which I have shown in this presentation, that we have, I think it's like 2 papers in Frontiers of Oncology. Let's go up. No, down. So that is example, right? So this one, Future Oncology 17, and the other one was, no, that's the model itself was in Israel. So that two papers there. So or just look at my name and you will find it.
Fine. And Dr. Slav, actually, it's quite interesting to see or to hear about the macroscopic spread map for us also. So could you please elaborate, how do you find this macroscopic spread map? How do you find the density of cancer cell and how do you calculate this?
That wasn't in my place. What to do? What to do? How do you find? So I know that there are people who are working and visualizing single cancer cells, but it's in petri dishes. How to do it in patient? That's what is this talk about? So just use your imagination and good ideas.
Okay, and I got another question from chat box. What about CSI, craniospinal radiation and large field treatment?
Flash radiation in large field. Well, it doesn't matter. So so far, as you have seen, the clinical example was for electrons, right? If it is a large field, the mechanism remain the same, right? the mechanism remains. But maybe it will be even more useful to have this kind of grid therapy and.
Okay. So any question from the audience side? Dr. Paul, do you want to comment something?
No, fine. We would like to just thank him for his talk and willingness to share. Thanks,
Okay.
Yartsev.
Thank you.
Thank you.
Good luck to Indian medical physicists. I've been in India twice, and I recall with great pleasure this country. It was snowing this night, and I can show you what kind of stuff is outside right now. You see?
Excellent.
It's all white.
I missed that.
It's pretty cold. Okay,
Yeah,
thank you very much.
Thank you.
Thank you. Thank you.
Before we wind up, Dr. Butts, please.
Paul, sir, please, can you conclude this?
Yeah, thank you, Dr. Yartsev, and to the friends for joining. Thanks to Vyas for the chairing the session. It has been wonderful. We apologize for the initial hitch-up for a few minutes, and we hope to keep meeting every month like this. Thank you, everyone.
It's very good. So I think that is one of the good sides of this COVID isolation, that people amazingly are now more connected than before by internet. Okay, thank you very much. Bye.
Thank you. Thanks.